Are you suffering from the brachial plexus blues? Do all these nerves to the upper limb have you feeling down? Well, take my advice. When in doubt, dance it out. Welcome to the second part of my Dancing the Brachial Plexus video. If you haven't had the opportunity to check out the first one, I suggest doing so. In that video, we learned the 5 terminal branches. In this video, we're now going to concentrate on branches that come off of the branches. We're also going to look at a preplexus nerve and then also the superior trunk. So let's learn those nerves and the movements that go along with them. Let's start with a preplexus nerve. Now this simply means that the nerve branches off of the spinal roots prior to the roots coming together and interweaving to begin the formation of the brachial plexus. Specifically, I'm talking about the long thoracic nerve, which is derived from levels C5, C6, and C7. The long thoracic nerve runs laterally against the chest wall, and it lies right next to a muscle, the serratus anterior muscle, which is really convenient because that's the muscle it innervates. Now, the serratus anterior muscle performs a host of functions, 2 of which we're going to highlight in this dance. The first of those is that the serratus anterior is a powerful protractor of the scapula. This simply means that it helps with sliding the scapula anteriorly against the chest wall to create, as some people might say, a poor posture. Because of the significance of this muscle involved with this action, the muscle actually has a nickname, which is the boxer's muscle. Why would we call it that? Well, because protraction or sliding that scapula anteriorly against the thoracic wall is really, really important in the act of punching. It helps you to fully extend that arm so that you can reach your opponent and knock them out. Another action that the serratus anterior muscle helps to perform is upward rotation of the scapula. Now, this simply means that it rotates the scapula to allow the glenoid fossa to be more superiorly placed. And this is a very important thing that needs to happen in raising your arms above the horizontal. So previously, we learned how the axillary nerve innervates the deltoid muscle that helps with abduction of the arm up into the horizontal. Once you get to the horizontal, however, then the humerus is stopped by the acromion process and can't go any further unless this upward rotation of the scapula occurs to allow this complex to upwardly rotate and allow the arm to go over the head. I would be remiss in my duties as an anatomist if I didn't go over the third function of serratus anterior, which is to keep the scapula against the thoracic wall. In order to understand this function, it's useful to understand the orientation of the muscle. Serratus anterior attaches to the medial border of the scapula, but on the anterior side, so that it is actually sandwiched between the scapula and the rib cage. The muscle then continues anteriorly against the thoracic wall and then has individual slips of muscles that attach to many of the individual ribs. How it works is that there are many muscles located on the posterior aspect of the scapula that when they contract, they are attempting to pull the medial border away. However, the positioning of serratus anterior then allows that medial border to stay in close to that rib cage. If a physician suspected injury to the long thoracic nerve, they would ask a patient to push against a wall. In the process of pushing against the wall, those posterior muscles would draw the medial border of the scapula away from the thorax then, indicating that serratus anterior isn't working. And this condition is referred to as winging of the scapula. So what's our dance move? We're going to combine the first two moves. So it'll look something like jab cross, arms over the head, jab cross, arms over the head. Now let's look at the trunks of the brachial plexus. C5 and C6 come together to form the superior trunk. C7 stays on its own to form the middle trunk, and C8 as well as T1 come together to form the inferior trunk. In this video, we're going to highlight the superior trunk because it's the area that is more vulnerable to injury out of the three trunks. An injury can arise from anything that increases the angle of the neck to the shoulder. Some more common ways to have this injury is being thrown from, say, a motorcycle in which you land on the ground like this, or even during a difficult birth when the head is excessively stretched or turned to help with the delivery of that baby. Injury to the superior trunk results in a common presentation, which is something like this. We can describe this as an adducted and medially rotated shoulder, as well as an extended elbow and a pronated forearm. This is also referred to as the waiter's tip posture. Now, why does it look like this? Well, basically, it's the loss of the C5 and C6 contributions to three very important nerves. One, the axillary, two, the suprascapular, and three, the musculocutaneous nerves. How does that work? Well, because of the loss of the axillary nerve, we've learned that the axillary nerve innervates the deltoid muscle, which helps with abduction. So if we've lost the axillary nerve, the arm is stuck in an adducted position. So we cannot abduct the arm. The medial rotation arises from the loss of two nerves. First, let's talk about the suprascapular. The suprascapular is the only nerve that branches off of that superior trunk. So it branches off and then it heads towards the shoulder to move superiorly to the scapula and then move to the posterior portion or behind the scapula where it innervates two muscles. One, the supraspinatus, two, the infraspinatus. Now hold on to that thought for just 1 second, because there's another muscle on the back of this scapula, which is teres minor. Teres minor receives a contribution from the axillary nerve. The reason I bring this muscle up is that the infraspinatus as well as teres minor wrap around to attach to the inferior or lower portion of the greater tubercle of the humerus. And because of their horizontal position, they help to laterally rotate the arm. So with the loss of these two muscles, as a result of the loss of the suprascapular and the axillary nerve, the shoulder falls into a medially rotated position. Lastly, let's look at the elbow. Why is it in the presentation that it's in? We said that it's extended as well as pronated. Well, we've also lost the C5, C6 contributions to the musculocutaneous nerve. That nerve is important in motor innervation to the anterior compartment of the arm, namely the brachialis as well as the biceps brachii, both of which are powerful flexors. So we've lost our ability to flex, and we've also lost our ability to supinate because of the loss of biceps brachii. What does all this mean to you? This is something that's very important for being able to diagnose, in that you see a patient with a position as such. So for our dance, we're going to assume that position. Adducted, medially rotated shoulder, extended elbow, and pronated forearm. Moving on to the branches of the branches. We're going to look at the anterior interosseous nerve, the recurrent median, as well as the posterior interosseous nerve. Starting with anterior interosseous. This nerve is a branch off of the median nerve, and it branches off just distal to the elbow. And it is going to provide motor innervation to the deepest muscles of that anterior compartment of the forearm, namely the flexor digitorum profundus, or at least the radial half of it, as well as flexor pollicis longus. It also innervates pronator quadratus, which is a deep muscle down by the wrist, although that has less significance in our dance. Now, let's say that you go to a physician and they suspect injury of this nerve. How are they going to test it? They are going to ask you to make an OK sign. If you can make a rounded OK sign, it means that this nerve is okay because of the actions of these two muscles. Flexor pollicis longus is specifically working on the interphalangeal joint of the thumb, whereas flexor digitorum profundus is working on the DIP joint. If the anterior interosseous nerve was not working properly, your OK sign would be flattened and have more of this appearance. So for our dance, how do we represent this nerve? We make an OK sign. Moving on to the recurrent median nerve. The recurrent median, as its name would suggest, is another branch off of the median nerve. The median nerve continues down the forearm, goes through that carpal tunnel, and then branches out into the hand. One of the branches that is going to come off, though, is going to move back on itself to innervate this thenar muscle group located at the base of the thumb. And this is the recurrent median. It innervates these three muscles, which are going to be the flexor pollicis brevis, abductor pollicis brevis, as well as the opponens pollicis. For our dance move, we're going to highlight the actions of opposition of the thumb through the opponens pollicis, as well as flexion of that metacarpal phalangeal joint through the flexor pollicis brevis. So for our dance, we're simply going to do this opposition. Our last nerve to highlight is the posterior interosseous nerve. Now, this nerve is a branch off of the radial nerve. So remember, anterior interosseous median nerve, posterior interosseous radial nerve. This nerve innervates the deepest layer of muscles on the posterior compartment of the forearm. In particular, the last muscle that it innervates is a muscle referred to as extensor indicis. As the name would suggest, this muscle is important for the ability to extend the index finger. So what are we doing for our dance? Just that. Extend the index finger, highlighting that extensor indicis. You guys ready to put all this together? I think you are. But this time we're going to add in the nerves that we learned from the first video as well. Let's do it. Starting with long thoracic nerve. Moving to superior trunk injury. Anterior interosseous. Recurrent median. Posterior interosseous. Now we're going to throw in the branches. Ulnar. Median. Radial. Good old extension. Axillary, abduction. Muscular cutaneous. Now we'll randomize. Anterior interosseous. Recurrent median. Superior trunk. Long thoracic. Axillary. Radial. Median. Ulnar. Superior trunk. Posterior interosseous. Axillary. Radial. Long thoracic.